Our topic for this session is epidural hemorrhage. Our first case is a classic epidural hemorrhage you see starting here in the floor of the lateral middle cranial fossa. There is an extraaxial lentiform hyperdensity consistent with an epidural hemorrhage. Note this does not cross the skull sutures typical for arterial epidurals in this location. Note the underlying deformity of the adjacent temporal lobe and the associated medial displacement of the uncus. Note also the distortion of the suprasellar cistern that causes. Here again, medial displacement of the uncus and the distortion of the cistern, just visible here as well. Note also the elevation, dilation, and distortion of the inferior horn of the left lateral ventricle. That can be a very useful indicator of the presence of extraaxial mass effect and has been the first finding I've identified in many more subtle epidural hemorrhages. See here again the extraaxial lentiform density not crossing the adjacent skull sutures. And appreciate the medial displacement of the uncus and distortion of the cistern. And lastly, we'll take a dedicated look at the dilated, elevated, and distorted inferior horn. These injuries are typically related to laceration of the middle meningeal artery and typically have a visible skull fracture. This one is particularly typical in that it's only visible on a single cut, and even then, only just so. I do encourage you to use the coronals in all head traumas, as those will frequently be more revealing in the presence of skull fractures. So that is an epidural hemorrhage with an associated temporal skull fracture and middle meningeal artery laceration. Our next case is a hyperacute epidural hemorrhage. A hyperacute epidural hemorrhage can be of mixed density. Sometimes these can be so hypodense as to be quite subtle. So that is a phenomenon I'd like you to keep an eye out for. Note here again, we have the dilation, displacement, and distortion of the inferior horn suggesting the presence of mass effect. This hemorrhage is more extensive than the still image suggested. You can see that markedly mixed density throughout this hemorrhage. There is overlying soft tissue density, as is typical with a coup injury to the brain. Here again, that distortion and displacement of the inferior horn, very nicely shown there. Here is the associated skull fracture. So that is a hyperacute epidural hemorrhage. Next, another hyperacute epidural hemorrhage, this one lying just above the transverse sinus and most likely venous in origin. It is also hypodense and could avoid detection. There is, however, a focus of intracranial gas. The skull fracture associated with this injury was not really very visible, though you can see overlying soft tissue swelling. All the same, the presence of that intracranial gas clearly denotes the presence of a skull fracture. As an additional distractor here, there was significant extraaxial density in a more contracute location, most likely a mix of subdural and subarachnoid. Here you see again, just above the transverse sinus, there is an extraaxial hypodense collection somewhat lentiform and consistent with a venous hyperacute epidural. Note also that single focus of intracranial gas, which is very helpful in calling your attention to that injury. So that is another hyperacute epidural hemorrhage. Our next case is an unusual hypodense epidural. You can see the extraaxial density here markedly less visible due to its reduced density. There is, of course, a focus of increased density posteriorly, consistent with clot. Its size is readily appreciated here, as is its lentiform shape. You can see this patient had significant atrophy, was probably more at risk for a typical subdural, but had a fall and was able to accommodate quite a bit of intracranial hemorrhage. And there you can see that extraaxial hypodensity with posterior density consistent with clot formation. When I first viewed this case, I thought surely this is a more remote hemorrhage that has had time to organize to a significant degree. The nursing home for this patient and the emergency room physician were adamant that the causative fall had occurred the night before. So that didn't really fit the time course with such a hypodense extraaxial hemorrhage as this, but this patient's hematocrit was 25. So it was extremely low, related to a chronic anemia, and that then attributes or accounts for this reduced density epidural hemorrhage. Our next case is a mixed arterial and venous epidural. The venous portion is here, overlying the anterior aspect of the temporal pole. These are related to sphenopalatine sinus injury and typically are less concerning than their arterial counterparts, which you see here. This one looks pretty typical, hyperdense, extraaxial, lentiform, and in a classic location for an epidural related to a middle meningeal artery laceration. Here the venous portion overlying the temporal pole, which is distinct from the arterial portion lying here more posteriorly. You can appreciate again the overlying soft tissue swelling. And here is the associated skull fracture, which in this case is visible on more than just one cut. You can see that extensive fracture then accounts for the fact that more than one vascular structure was injured. So that is a case of mixed arterial and venous epidural hemorrhage. Our next case is a venous epidural, this one in the classic frontal location. This relatively hypodense but lentiform collection, you can see, does cross the midline in the frontal region, which venous epidurals in this location can do. This one is relatively apparent on the axials, but you can see how they could be quite subtle without the coronal images, at least on occasion. Here's the associated skull fracture, which of course passes through the superior sagittal sinus, and for that matter, the frontal sinus. But the dural venous sinus is quite clearly affected, and that would be the anterior aspect of the superior sagittal sinus. Following this skull fracture all the way up, you can see an interesting phenomenon here, which is a diastatic suture. So that is a frontal venous epidural hemorrhage. Our next case is another frontal venous epidural, this one to specifically demonstrate the value of coronal images. Granted, this is visible on the axial images, but only on the uppermost cuts and in a region where we're accustomed to at least some artifact obscuring findings. But on the coronal, that extraaxial, hyperdense, lentiform entity is clearly visible, as is the overlying soft tissue swelling. So here on the axials, you can see there is probably mixed subdural and subarachnoid hemorrhage as well, lower down. But only on these uppermost cuts is the actual epidural visible. And there it is, clearly identifiable on the coronal. So that is a venous epidural, where we are helped by coronal imaging. This is, I believe, becoming the standard for all acute neuroimaging. Essentially, all of the facilities that we interact with are doing coronals on all of their head CTs. So our last case is a venous epidural related to transverse sinus injury. This one does in fact cross the midline, as many but not all of these posterior fossa venous epidurals do. You can see there the extraaxial density, and again we have dilation of the inferior horns. This is most likely an early manifestation of hydrocephalus rather than specifically indicating the presence of an extraaxial mass effect. But in either case, in such a young brain, the prominence of those inferior horns is a very important finding to note. There it is on the cine, a bilobed but still lentiform extraaxial density, all the more concerning by virtue of its posterior fossa location, and most likely resulting in early hydrocephalus, which gives us these prominent inferior horns. So that was a venous epidural hemorrhage related to transverse sinus injury. And that concludes this session on epidural hemorrhage.